Okay, we're back. And the very, very bottom one we're going to talk about here for first trimester is going to be EDB, means estimated date of birth, and you'll also see it written as estimated date of confinement. So it can either be EDB for estimated date of birth or EDC. And using Nagel's rule, let's look at that right now. Most of the time, people have no idea of when they are ovulating. And so they go with the menstrual cycle because most people know, they have an idea of when they last had a menstrual cycle. So what they do to try to get the birth date, they go back to the last menstrual cycle, the first day of the last menstrual cycle. And then you're going to subtract 3 months and you're going to add 7 days. And that's how we get Nagel's rule. So let's do one right now. Let's see, where are we? We're in May. So let's see, the first day of the last menstrual cycle was, we'll say April 14th. So we're going to subtract 3 months. We're going to go to March 14th, February 14th, January 14th, and we're going to add 7 days, which would be the 21st. So they would give you a due date of January 21. Does that make sense? So that's what it is. The formula is, again, the first day of the last menstrual cycle, you're going to subtract 3 months and add 7 days. If you know when you're ovulating and you know when the first day of the last menstrual cycle was, and you subtract 3 months and subtract 7 days, that's actually a much, much better due date. But most people don't know that. So don't even put that to memory. Do the Nagel's rule, and that's what you'll be tested on, which is to subtract 3 months and add 7 days. Let's do another one. Let's see. We'll say we really have no idea what's going on, even though it's the very end of May or beginning of June, whenever this lecture comes off. And we will say that the last menstrual cycle was, let's try April 23rd. Okay, so let's do another one. We're going to subtract 3 months from that date. So April 23rd to March 23rd to February 23rd to January 23rd and add 7 days. So the due date would be January 30th, 2021. So we will be doing that also together. So don't worry if you didn't get it, but they're kind of fun to do. Okay, so the health assessment of the first trimester, look at this screen. It's everything and anything. And so what I wanted to zero in on right now is most of you know all of this. You know what hemoglobin, fasting blood sugar, you know what a total cholesterol is, a lipid profile, UA, syphilis serology. Serology is just blood, and that usually is reflected when you are doing what I say is a care map, but we do an assessment in OB. It's under a VDRL or RPR. It's syphilis and gonorrhea. Mammogram, you know what that is. ABO and RH typing, those are blood types, and RH is either negative or positive. The rest you can read through. I wanted to talk about the torch screen because most of you are not familiar with that, and that's very, very important in this area. Torch screen is an acronym for a group of infections that can negatively affect a woman who is pregnant. All of these infections listed in the torch, and there are many, can cross the placenta and have teratogenic effects on the fetus, which we just talked about what a teratogen was. The T stands for toxoplasmosis. And you can get this from raw or undercooked meat or handling of cat feces. Now you notice I did not say fish. I just said meat. It's raw or undercooked meat or handling of cat feces, and that is toxoplasmosis. You can have flu-like symptoms or lymphadenopathy, which just means, large lymph glands. The treatment is a medication called spiramycin. That's S as in Sam, Piramycin. And then some of the sulfidines. This can be potentially harmful to the fetus, but its parasitic treatment is essential. The O stands for all other infections. So that's why I mean it can be many. These would be all of the STDs that are not listed in here, all of the syphilis, gonorrhea, all of the hepatitis, A through G, HIV, all of those is listed in the other. The R stands for rubella or German measles. Our risk factors are the people that are in contact with children who have rashes or infants born to mothers who had a rubella during pregnancy. Mothers will have a rash. They can have muscle aches, joint pain, and lymphedema. Again, large lymph floating around. Fetal consequences include a miscarriage with rubella, congenital anomalies, and even death. Obviously, miscarriage would be death, but they're talking about a death of stillborn, a baby going 40 weeks or 38 weeks and dying. So that's rubella, and the people that are in a little bit more susceptible to this would be like young women who teach grade school. They should avoid crowds of young children, preschool, and that teach grade school. Or if they don't have a titer for this, a higher titer, meaning they're not immune, that they could be exposed to this. And so they'll immunize women with low titers prior to pregnancy. We can't do it while they're pregnant. They have to do it afterwards. C means cytomegalovirus or CMV. Cytomegalovirus. This is transmitted by droplet infection from person to person. Virus is found in semen, cervical fluids, vaginal secretions, breast milk, placental tissue, urine, feces, and blood. The latent virus may be reactivated and cause disease to the fetus in utero or during passage through the birth canal. The problem with this one is that mother can be asymptomatic or they have symptoms like mononucleosis. And so they're not treated. So again, prevent exposure by frequent hand washing before eating and avoiding crowds of young children. And then H is herpes simplex virus or HSV, not complex, but simplex. Direct contact with oral or genital lesions. Transmission to the fetus is greatest during a vaginal birth. So if there's active lesions, we cannot let them do a vaginal birth with this one. For mom will be lesions on the initial outbreak. They obtain cultures on women with HSV or near term. C-section delivery is recommended only for mom with active lesions, meaning if they've been exposed to it but treated and they're not active lesions, they can definitely have a vaginal delivery. But the fetus is directly exposed coming through the vagina if those lesions are active, and the baby can be born blind and all kinds of other problems. So that's the issue with that one. The torch screen is very big. I've worked with nurses when the doctor doesn't know what's going on with the kid, and he said, can we order a torch screen? And there are nurses that kind of look at you and they don't know what they're talking about, and that's kind of embarrassing. So we all need to be familiar with that. GBS is group beta strep, and this is normally found in a lot of vaginal areas in women. Normal flora. Before 1992, we actually weren't checking for this, and a lot of kids that were born with great APGARs, 7 and 9, 8 and 9, 9 and 10, would die because they got group beta strep, which is a horrendous bacteria in the blood. We don't really think mom's and baby's blood ever mixes, but we know it does somewhere during the delivery because of all the RH problems we can have and because of this situation. So now they screen them at 35 to 37 weeks because if they're what we call GBS positive, meaning they carry group beta strep in the vaginal area, again, normal for that area, but we don't want it getting in the baby's blood. We know strep shut down the heart, shut down the kidney, and then they die. So what they'll do is they'll treat them. It's up to 4 to 6 doses of penicillin. If they're allergic to penicillin, they'll give them a cephalosporin of some kind. So that's what GBS is. And then, of course, we're going to screen for hepatitis B because it's the worst one to go transplacentally for the baby. And here it is outlined again just to let you know what the acronyms mean. There's toxoplasmosis. O is all other. All the hepatitis, all of the STDs, HIV. There's rubella, CMV, and HSV2. Infected fetus with any of this may suffer from what we call IUGR or intrauterine growth restriction. They can be premature, fetal death, or postnatal infection, which can lead to sepsis and they can die. And you can see how it's transmitted either across the placenta or during delivery. That would be the GBS one, but that's not included in TORCH. Okay, second trimester, of course, we're going to be looking at the fundal height. How high are they and what's the average? Are they planning to breast or bottle feed? And of course, we're going to push breast unless they absolutely can't for a zillion reasons. A lifestyle, again, we're going to be talking about all of these different entities. Fetal movement, again, fundal height. Complications, at this point, we're going to start talking about them. What is preterm labor? Because it's basically going into labor at 20 weeks. Gestational hypertension, gestational diabetes, premature rupture of membranes. If their water breaks, even with no contractions, they must come in. Because when the water breaks, that means there's this opening into the cervix. They can get an infection. And then prepare for childbirth. Definitely going to push a lot of education for self-care. And again, recognizing preterm labor after the 20th week and before the 37th week. If fundal height is 3 to 4 centimeters more or less than expected, further investigation goes on. What's going on with the placenta if it's too small, and if it's not too small, if it's large, they may be looking for extra bursts in there. Okay, it looks like I'm almost out of time again, so I'm going to stop right here, and then we'll go on with the third trimester when I come back. See you in a